everybody. Welcome to our second webinar as part of the Catalyst for Change Analytics, the Intersection of Equity and Value webinar. We are so appreciative to have each of you join us, the Foundation for Healthcare Quality, Washington Health Alliance, and Comagine Health in this webinar event today. Before we jump in, we just want to go over some housekeeping items. You have all been placed on mute upon entering this webinar. And we are unable to have you come off of mute later in the event. So if you do have any questions for our speakers, please write your questions in the Q&A box that's located at the bottom of your screen. We will have time to ask some questions to our speakers individually, but then also as a panelist as a whole. So we really appreciate those questions to engage with our speakers and have a rich conversation. The webinar will be recorded today, and we plan to send out the recording to each of you after this event, and will also be placed on our website. So we just want to take a moment and discuss, why are we here? What is this webinar on today? In healthcare, we recognize that you cannot have quality without equity. And in today's healthcare landscape, harnessing data to promote equity and drive value has become more critical than ever. Transformative change that centers equity needs to be driven by a multifaceted approach that encompasses collecting, analyzing, and applying data insights. In this webinar, we will explore how data can support efforts to provide more equitable, high-value care through presentations from different stakeholder groups within our healthcare ecosystem. Our agenda today is just to provide an introduction. We'll have some mini presentations from 4 different speakers. We'll have a large group discussion, and then we will wrap up in closing. But first, as we begin, I'd like to take a moment to bring Ginny Weir, Sharon Elorante, and Emily Transu forward to share work their organizations are doing in the health equity and VBP space. So I'll pass it to Ginny.
Thanks, Emily. And good afternoon and welcome everyone to the second of this year's Catalyst for Change webinar series. This, of course, as Emily said, focused on analytics at the intersection of equity and value. I'm Ginny Weir. I have the pleasure of serving as the CEO of the Foundation for Healthcare Quality. And we have really been part of our healthcare ecosystem since the late 80s. We convene communities of clinicians dedicated to quality improvement, derived from chart-abstracted clinical data. These are our care outcomes assessment programs for cardiac care, obstetric care, general surgery, and spine surgery, as well as our newly developed community birth data registry, the Public-Private BRIE Collaborative, the Washington Patient Safety Coalition, and Smooth Transitions. I think all of our programs really live at this intersection of equity and value, but our COPE programs with their meaningful clinical data are really most closely aligned with the work of our speakers today. This ability to stratify processes of care like door-to-balloon time or time spent in active labor by race or by payer really gives us insight into what needs to change and a pathway for us to help design improvement initiatives. I'm looking forward to this day's speakers to really help us improve our work and partner to improve the health of everyone in our region and in our state. It's my pleasure to let Dr. Sharon Elorante introduce the Washington Health Alliance. Sharon?
Great. Thank you so much, Ginny. As has been said, I'm Sharon Elorante. I'm the medical director for the Washington Health Alliance. For those who do not know, the Alliance is a purchaser-led, multi-stakeholder membership organization. Our membership comprises healthcare purchasers, health plans, providers, and allied organizations. And we all work together to help assure that the healthcare that purchasers arrange to provide for their employees is of high quality, of reasonable cost, and also is equitable. To that end, for the past 2 years, we've been using the Neighborhood Atlas, which is a way to assess social drivers of health based on the place of residence, to look at data from our all-payer claims database to identify the impact of social drivers of health on things such as healthcare quality, total cost, and the types and extent of healthcare waste that exist based on where a person lives. We then work with our committees to develop initiatives to address any identified inequities. Our data are all publicly available at this time on wacommunitycheckup.org. So if you haven't seen it, this isn't something we're keeping under our hat. You can go on and check those out. We are very proud to participate in these jointly offered webinars that are focused on health equity. And thank you all for attending today. Pass it off to Emily.
Thanks so much. A call out to the Alliance's recent program last week in person around costs in hospitals, among other things. I'm Emily Trancio. I'm the Chief Clinical Officer at Comagine Health. Comagine is a nationwide nonprofit that works on healthcare quality in a number of different arenas, including care management, system-wide quality improvement, research evaluation, and data solutions. I feel as though I've talked a lot in these settings about our work in Washington, but wanted to call out today some of the work that we do in Oregon, including convening the Oregon Perinatal Collaborative, which is linked to the Oregon Maternal Data Center. This is a platform that provides hospitals with real-time feedback on key maternal and infant health quality metrics. I think meshes nicely with some of the work that Jenny was talking about with the COPE programs. Comagine leverages these data to provide nuanced reporting on the state of maternity care for a number of different audiences, including applying an equity lens. I think we're all aware that there are critical disparities in maternity care across the country, including here in the Northwest, and this is really a place where data are essential to help us identify root causes and identify and promote successful approaches to improvement. So we're really excited at Comagine to be part of that work. I will hand back to get started today with our speakers.
Thank you. Well, we are so excited to hear from our speakers today. We have a great panel. We will first hear from Dr. Christopher Chen from Washington HCA. We have Dr. John Liu from Amazon Benefits. We have Kelsey Potter from Coordinated Care. And we have Dr. Josh Liao from UT Southwestern. So I'll pass it off to Chris Chen.
Great. Thanks so much, Emily. And thank you so much for having me at today's webinar. I'm really looking forward to sharing the Healthcare Authority perspective. As an introduction, my name is Christopher Chen, and I work as a medical director for Medicaid at the Healthcare Authority, where at the core of my role is supporting the development of clinical policies, but I also support a number of other strategic priorities around health equity, health IT, and quality. So today I'm going to share a little bit about how the Healthcare Authority thinks about analytics at the intersection of equity and value, with a specific focus on data related to social determinants and health equity. And I'll share a background of our agency and our work in this area, then move on to work in improving data collection, standards, and exchange. I'll share with you some key examples of using data to improve equity and value at the agency, and then end with some overarching considerations and themes. So for those of you who aren't familiar with the Healthcare Authority, we are the state's largest healthcare purchaser. We wear a number of different hats, two of which are highlighted here. We purchase healthcare for more than
we are not seeing
Oh, I'm sorry.
That is okay.
I shared my screen here.
If not, I can bring up your slides too.
Yes, I got it. Thank you.
You're welcome.
And you can see it right now, Emily. Great. And so we purchase healthcare for more than 2.5 million Washington residents through Apple Health, our Medicaid program, as well as the Public Employee Benefits Board program and the School Employee Benefits Board program. Although mostly today I'll be speaking to the Medicaid side of the house. I want to just start off with our mission, vision, and values here. Our vision is a healthier Washington, and our mission is to provide high-quality healthcare through innovative health policies and purchasing strategies. And want to emphasize that health equity is one of our core values here at the Healthcare Authority, and helping ensure everyone has the opportunity to obtain whole person health. And I think that's really relevant to our conversation today about how we use data to advance and improve equity and quality. Medicaid programs have a long history of collecting and utilizing social determinants data. This diagram is from a recent MacPac report on Medicaid collection of demographic data. Primary uses for demographic and social determinants data include program administration, as well as identifying and assessing disparities. For program administration, you can see there are a number of uses, including determining eligibility, providing translate accessible application and education materials, And under identifying and assessing disparities, demographic data is really critical to conduct research, to understand populations and inform policy, measure needs and outcomes, and identify inequities in access to care and services. And we've really tried to do this work in Washington as well. Along those lines, Washington Medicaid is a leader in race ethnicity data quality. This is also from a recent MACPAC report from 2023 that used the Data Quality Atlas tool to assess state race and ethnicity data quality across the country. And you'll see up in the top left here, Washington has low concerns, which is probably not the most flattering description, but I translated that to say that we are relatively confident in our data. And this data quality was assessed around two criteria, the first of which was completeness. And we have over 90% completeness of race ethnicity data. The second criteria is around accuracy. And so benchmarking the data that we produce and submit to CMS as compared to the American Community Survey. Of course, this doesn't mean that we don't have work to improve upon. Along those lines, I want to highlight some efforts, both past and ongoing, that demonstrate our dedication to improving data collection standards and exchange. Under improving data collection, we have a partnership with our managed care organizations. As many of you know, 85% of Medicaid in Washington is managed by 5 managed care organizations, also known as MCOs, who perform an initial health screen. These initial health screens are required to contain elements related to social determinants of health. And we've been working on standardizing the initial health screens, as well as using standards that are interoperable and facilitate better data exchange. We've also been working on updating our language to questionnaires related to data collection that clarify the intent and use. And this is really trying to serve the goal of establishing trust with clients that their data will be used for good purposes to improve quality. And most recently, we were funded from this past legislative session to implement social determinants of health risk assessment reimbursement. And this will go live in January 2025. We're very excited to be able to reimburse for these services because we know many providers are actively assessing social determinants of health for the patients that they serve. And this takes time, and we'll soon be able to reimburse it for specific populations. Under the category of implementing data standards, I want to highlight the sexual orientation gender identity work group, which was a work group that was stood up from our Health and Human Services IT coalition. This work group was created to address existing inequities in the way that sex and gender identity data is captured, and developed best practices across our agencies for collecting and utilizing this data, and was conducted in partnership with the LGBTQ Commission and the Rainbow Alliance and Inclusion Network. We're also actively working on implementing the new OMB standards that many of you might be familiar with, that have transitioned to single combined race ethnicity questions, minimum and detailed categories, and offered clarity on multiracial categories as well as data sources. In the bucket of supporting data exchange, we have a big project going on in our MTP, our Medicaid Transformation Project waiver, supporting community information exchange. And this is a resource and referral platform that will be available as an option to our accountable communities of health to assist with the coordination of and connection of to necessary community resources. And I probably won't go into this slide in depth, but I want to highlight that we've also been working with NASHB Learning Lab series, which supports states in data-driven policymaking approaches to addressing health disparities. And this work plan captures some of the tasks that I mentioned before. So it's not enough to collect or exchange data, but the goal of collecting social determinants and equity-related data is to ultimately improve quality and value. And so I want to highlight 4 areas of examples where we're doing this in expanding access and coverage, effectively coordinating care, improving quality, and finally addressing health-related social needs. So under expanding access and coverage, the Healthcare Authority is really dedicated to ensuring that Washingtonians have access to care. And social determinants are an important component of determining Medicaid eligibility, including things like income and resources, living arrangements, and foster care status. As most people know, the Healthcare Authority implemented the Affordable Care Act expansion in 2014, and more recent initiatives to increase coverage include postpartum extension, so extending Medicaid eligibility to a year after birth, continuous eligibility for children under 6, re-entry for justice-involved populations, and so extending Medicaid coverage to 30 days before release from an incarceration setting, as well as Apple Health expansion, which the program is launching soon to expand coverage, including those for undocumented immigrants. Another area where we've been working on expanding access and coverage is under our partnership with the Benefits Data Trust, where the Washington Health and Human Services Coalition has created a state action plan for removing barriers to health and human services. Many of you know that applying for public benefits, whether it be Medicaid or cash or food assistance, can be very administratively burdensome. In fact, as part of this project, we recently conducted a human-centered design process that identified that there are 1,344 questions used across 4 assistance programs to assess financial eligibility, and 155 of these questions were found to be duplicative. Ultimately, our goal is to remove client barriers to accessing benefits and get to a 20-minute application where clients can immediately know their eligibility status for multiple benefits. And this will be really important to addressing social determinants of health for our low-income population that we serve. Another bucket where we use social determinants and equity data to improve equity and value is by effectively coordinating care. We partner very closely with the Department of Social and Human Services, under which sits a section called Research and Data Analytics Group. I have a pretty complicated diagram on the right-hand side, which I'm sure you can't see, but want to demonstrate that there is a really, really robust set of integrated client databases across the health and human services agencies and beyond that incorporate not just medical, behavioral health, and long-term care data, but also social services data that are really important for managing the care for the clients that we serve. One example of this is PRISM, which is a predictive modeling tool to support care management for high-risk Medicaid clients that incorporates medical, behavioral health, and social data. And another way that these integrated client databases are used are to perform studies to understand the population that we serve. And one example is by examining the prevalence of homelessness and housing instability among adults and system-involved youth. There are a number of other studies that are performed by RDA that really inform the policies and programs that we launch, including criminal justice, involved populations, studies on youth and adolescents, et cetera. The third area I want to highlight today was improving quality with an equity lens. And so we are striving as an agency to more systematically report differences in quality outcomes and measures. And this on the right-hand side, I have a graph, which is from our external quality review organizational report, also known as our ECRO report, which is done in partnership with Comagine. And over the last few years, we've been more systematically refining our analyses on identifying quality measures by race ethnicity. And this is really important to be able to identify disparities so that we can start addressing them. Accordingly, the managed care organizations undergo a PIP, quality improvement projects. And this year we're doing this in partnership with Advancing Health Equity to identify a quality measure that is stratified by race ethnicity, where we can focus on improving quality for subpopulations with lower quality. And looking ahead, we're interested in incorporating an equity measure into our value-based payment withhold as well. Lastly, I wanted to highlight that we are newly reimbursing for specific health-related social needs services as well. This, as part of our waiver project, as part of the Medicaid transformation project, actually this slide starting here is an older iteration of ways that we reimburse for health-related social needs services, specifically supportive employment and supportive housing services. These are services administered by community-based organizations that can help clients get employment or housing. And this has been demonstrated in the studies as shown here performed by RDA to reduce emergency department visits, reduce hospitalizations. It really was an impressive demonstration that addressing social determinants can improve health outcomes. As part of our MTP 2.0, there will be a whole new suite of health-related social needs services that can address unmet social needs like housing and nutrition, and a list of those are here. Finally, wrapping up, I just want to end with some overarching considerations and themes as we approach social determinants data collection and using it to improve equity and value. From an administrative burden perspective, we know that low-income individuals often face a very high degree of administrative burden when trying to access public benefit programs. We really want to be mindful that the data that's collected is used, which leads to the next consideration around trust. Client needs should be addressed when reported, and it doesn't do anyone good to feel like they've been sharing the areas where they need and to not have them actually addressed, and that really kind of diminishes trust, and that it really is a goal of ours to be able to preserve that. And then finally on privacy, avoiding stigmatization of individuals because of their health-related social needs is important, and clients should be able to have control over the data. So these are kind of themes that we try to layer into any of our policies and programs that we administer. And with that, I'll pass it back over to you, Emily.
Thanks so much. A question I had for you is, as you were speaking, you were highlighting how there was like a survey or something that had a lot of duplicative questions on it, this form. How are you all working through that to ensure that you're streamlining the process so it takes less time for the user to complete the form, but also ensuring that you're getting the full amount of information you all need to better support your client as well?
Yeah, thank you. Yeah, so the HHS IT Coalition project that we're doing with Benefits Data Trust really systematically evaluated those applications for major public benefit programs with a human-centered design process. And that's a specific kind of approach that really focuses on the individual and the user and what they face rather than coming at things from an institutional perspective. To your question, there really is a lot of the questions that are asked are also requirements from our federal partners that oversee these programs. And so there is a little bit of a dialogue and kind of understanding what data is adequate and necessary to administer certain programs and what areas we have flexibility on. But certainly the intent is to try to minimize duplication.
Thank you so much. I really appreciate that answer and your presentation. We'll now invite our next speaker up. We have Dr. John Liu.
Hello. Can you hear me okay?
Yes, we can.
Just checking. Thank you so much for the invitation to be here and be part of this important conversation. It's impossible to follow Chris Chen in any presentation, so just everyone recalibrate your expectations. But my name is John Liu. I'm an internal medicine physician, primary care doc, and I lead population health and health equity for Amazon Global Benefits Health and Wellness. And unlike my colleagues today, I'm not going to be able to get into a lot of quantitative or program-related detail for corporate and employee privacy reasons, but I've been asked to deliver an employer's perspective on value and equity, and so that's what I'm hoping to do and hopefully add some value through that lens. On the next slide, you'll see one thing, which is the most common feedback that I get in talking to colleagues or friends about Amazon is, oh gosh, I didn't know Amazon did that. And that's because I think we often think about Amazon as the entity that brings us our boxes. We open our door and there's a pile of boxes there with our diapers and razor blades and what have you. But Amazon actually does a lot more. We have a whole bunch of stores, a bunch of devices, entertainment offerings, Amazon Web Services, burgeoning artificial intelligence, delivery, logistics, a whole bunch of stuff. Take Project Kuiper, for example. That is the successful program to launch into orbit, low Earth orbit satellites to bring broadband to a global population. That's pretty wild in my book. And so across all of these diverse businesses is this through line of customer obsession, of doing better for our customers, delivering better experiences, building new innovative opportunities for our customers every single day. And that's true of our external customers, but that's also true of our internal customers, which is the team that I'm on. So on the next slide, you'll see a little bit about what we do in Amazon Benefits Global Health and Wellness. And we have a vision here to empower our employees, known as Amazonians, to have healthy, productive, and meaningful lives. Right? The mission is there. I won't read it because it's a little bit wordy, but you'll see a lot of the DNA from the quadruple aim and the quintuple aim in there very purposefully. And if you don't mind clicking, the way that we execute on this vision and this mission is through very candidly through delivery of fantastic benefits, I think. These are robust physical health, behavioral health, pharmacy, dental vision benefits starting on day one of employment, no waiting period. Medical advice line that's staffed 24/7, musculoskeletal prevention programs delivered digitally, paid family leave, including for supportive and adoptive parents, expert medical opinion for cancer-related issues. And we actually have a team of in-house social workers and nurses, people with those backgrounds, to support employees and families experiencing a diagnosis of cancer, so that, to Chris's point earlier, we can take off some of that administrative burden, because what you should be focusing on is healing when you have cancer, not filling out paperwork and dealing with HR. We also have an anytime pay program that allows employees to access the vast majority of the money that they have earned before their next paycheck. We have a very popular career choice program that fully funds college tuition or high school or GED and other educational opportunities for our frontline employees. We have fertility benefits and gender affirming care and a whole portfolio we can spend hours on to support behavioral health, as well as a set of neighborhood health centers in medically underserved areas in the country, which I'll talk about a little bit later on. And this is just a partial listing. If you're interested in a lot more, go to aboutamazon.com and you'll find a bunch there. But benefits are just one lens through which I think corporations and employers can impact the health and well-being of our people. On the next slide, my thesis is that employers, if we truly want to work backwards and improve the health of our people and their families and the communities, then we should take a page out of the public health book. And the MPHs in the room can know this far better than me. But from my understanding, the social ecological model is really this fantastic framework that says if we want to sustainably, scalably improve health, then we need to impact across all these different spheres of influence. And as that applies to the employer, I think employers have multiple areas in which we can push levers to impact. Right. So this is my personal thesis here on how employers can impact health. If you don't mind clicking through, here are just some questions that I invite employers to think about as you're approaching your work. One is, of course, policy. How are you showing up on the Hill and in your local governments to advocate for your people? How are you partnering with industry groups to advocate for your employees and pushing our partners and carriers to have better analytics and deliver better quality of care? Environment, what are you doing to get to net zero? How are you strengthening your community? Are you an active community pillar, or are you leeching from the community, so to speak? Are our policies, beyond just benefits, are our policies and our services helping employee health or detracting from it? Do we have things like lactation rooms and multi-faith rooms and appropriate accommodations programs to support employees beyond benefits? Talked about benefits in the last slide, I'll skip that. But then getting into health behaviors, without being paternalistic, how do we help leverage our in-house expertise to help make the healthy choice the easy choice through behavioral economics and what have you? And how do we leverage all of our expertise to help employees understand, well, when should I go to the ER? When should I go to urgent care? When should I see a primary care doc? And what benefits are actually available to me? So to make that real, I put some examples. This is just few examples on the next slide of how Amazon is approaching some of these different things. And I take no credit for the vast majority of this list, but I think these are all really interesting things that Amazon as a company is doing. From a policy perspective, if you go to Amazon.com, you'll see 13 different published positions where Amazon has come out and said, this is what we believe. Right? From federal minimum wage reform to climate change, to LGBTQ rights, to housing equity, a bunch more there. From the industry perspective, it's collaborations with BRIE, it's collaborations with the Integrated Benefits Institute, Purchaser Business Group on Health, and the list goes on. It's our work with the White House Cancer Moonshot to improve cancer screening rates nationally. Amazon has a $2 billion private pledge, and we have a public commitment to reach net zero by 2040. A lot of people don't know from a community lens, Amazon has a $2 billion housing equity fund. And it was just announced yesterday, actually, an additional $1.4 billion added for a total net of, I think, $3.6 billion in housing equity. In addition to that, Amazon donates a bunch to communities, but also relief items and leverages its logistics network for good. Zooming into the HR perspective, I mentioned some of the policies that we're bringing to bear to improve health, as well as company services. But beyond lactation rooms and the like, we've set up new partnerships with the CDC's Hear Her campaign to bring maternal health equity resources to our people, set up a partnership with the NIH's All of Us research program so that the next generation of medical research hopefully is done with underserved populations in mind, and underrepresented populations can be part of that research and not be left out from the benefits of that research, right? Talked a bunch about benefits, so I'll skip that, but getting into behaviors, we have an Eat Well program that helps people understand when they're at a micro market, what are the healthy choices, what are some of the less healthy choices, so you can make an informed decision. And then we partner up and down the organization with affinity groups and otherwise to help folks understand what is available to them in their benefits portfolio. So those are just some examples of how we're applying that framework to improve the health of our people. That said, we all face some headwinds, and these headwinds that I listed here, just stream of consciousness, aren't just exclusive to employers. I'm sure all of us in this room here are touched by some of these challenges. I've been asked to zoom in on one piece, which is the heterogeneous data. So take something as simple as cancer screening. As a primary care doc, this is bread and butter, right? It's breast cancer screening, colorectal cancer screening, and the like. And yet, across my partners in industry, carriers, point solutions, PBMs, providers, what I see in the reports that I get are different rates, and the rates are unfortunately not apples to apples. I can't compare these because on one hand, one vendor is telling me, well, here are all the claims across this calendar year. Okay, well, and then another carrier is saying, here are all the claims, but just for members that have been continuously enrolled for 1 year. And another one has yet another definition for the denominator. And so now we have apples to bananas to oranges and other types of fruit. And so now the work is really working with these partners to get to one common source of truth so that we can actually do that good work of holding people to higher bars and improvement over time. On the next slide is just a little bit on what employers like us find to be super important. I won't go through all of these for time purposes, but from the voice, I just want to zoom in on the voice of the customer, because the data on feedback from the customer is fundamentally important. We have a few digital mechanisms to hear from our customers, our employees. One is connections. Every day when I log on to my computer, there's always one question waiting for me to get a pulse on my experience as an employee. And then later today, I'm driving out to a fulfillment center to go to the Gemba and talk to people and observe and learn from our folks on the ground. And then I'll close out with this one slide, which is a spotlight on our neighborhood health centers. It's a collaboration with Crossover Health, where for years now, we have these fantastic whole person care clinics across 5 regions in the United States, delivering physical health, mental health, PTOT, chiropractic care, health coaching, dietitian, nutritionist services, on-site labs, the works. And while I can't get into the quantitative details today, suffice to say, patient experience is fantastic. There's a lot of engagement in preventive care. We're seeing quality and outcome improvements in chronic condition management. And what I've really loved is the opportunity to co-innovate when it comes to SDOH and health equity. where we are universally screening for social determinants of health needs, referring to appropriate in-house and community resources, as well as screening for and collecting that important data of real and SOGI and starting that important work of ensuring our quality and process measures are stratified by those metrics. So I think that's my time, but I just wanted to share that perspective from a large employer on this important. Thanks.
Thank you so much. That was really helpful. I have a question for you. I know we kind of talked about this, and then also as we were seeing within your slides, we were talking about ensuring the customer's voice is centered within your work and how that's a very pivotal piece of this. I'm hoping you can provide a little more context on how in your role or at your organization you practice this.
Absolutely. So hearing the voice of the customer is super important. We have a few mechanisms, like I mentioned, the connections and the how's my driving, which is a mechanism to get feedback on the benefits that we're delivering. But also we try to go to the Gemba and hear from people directly, whether it's in focus groups or one-on-one conversations, hearing from leaders. We have an escalation process where whenever there's any turbulence, press a button and talk to us. We have a very active Slack channel as well, where people are able to raise their hands and seek help. And then we also have a bunch of surveys and try to get as scientific as we can in hearing the voice of our people. So
thanks. Well,
Thank
we
you.
really appreciate you joining us today, and we'll transition to our third speaker. We'll invite Kelsey Potter forward. Hi, Kelsey.
Hi there. All right, Emily, are you pulling up the slides? Great, thank you. Well, I believe I have a tough act to follow, but thank you for including me. As mentioned, I am Kelsey Potter. I use she, her pronouns, and I'm speaking to you today from the ancestral homelands of the Kelp tribe. I am fortunate enough to serve as Coordinated Care's Vice President of Apple Health, or Medicaid, which is one of the 5 Medicaid managed care plans contracted with the Healthcare Authority. The health plan perspective that I'd like to add today is the importance of both data, community and voice, and investment to really understand and support equity work. Today, I'm going to be sharing some examples of how data has influenced the design of Coordinated Care's food security programs and how we partner with community-led organizations to ensure that these programs are centered in equity work. Next slide, please. Before I begin, just a little background on Coordinated Care and our mission to transform the health of the community one person at a time. As I mentioned, Coordinated Care is contracted with the Healthcare Authority to deliver both no and low-cost health insurance plans to individuals and families in Washington State. We're a local plan with staff living across Washington's communities, and we serve more than 300,000 people and Washingtonians, or people who are our neighbors. Next slide. A cornerstone of our mission and commitment to those that we serve is continued community investment. In order to center our work in equity, we believe that it's critical to lean into data and partner with community organizations that not only listen and learn, but fund initiatives in a way that's meaningful to communities. We've really focused our giving in 3 ways, and these ways align with the priorities as outlined by Dr. Chen, and they include equity and equity-based projects really addressing healthcare disparities and equities among communities of color, LGBT communities, and individuals impacted by incarceration, and other populations that we see underrepresented in our data for many reasons. The next tier of our investment is really focused in health-related social needs or social determinants of health. These are programs that we funded that really focus on addressing things like nutrition insecurity, access to education, transportation, and the continued housing crisis. And last, really focusing our funding on capacity building. I think a lot of what the pandemic has taught us is that it is important to invest in your teams, as outlined by Dr. Liu. We need to make sure that we have the workforce as a health plan to serve the communities that we're fortunate to cover. Next slide. So how do we do this work? To begin, we gain insight from what our data tells or doesn't tell us. As supported by Centene, which is our parent company, Coordinated Care has direct insight into community social drivers of health. This is gleaned from publicly available data and proprietary data that we ingest as a payer, but we really use it to help us identify gaps in resources like access to nutrition, where food deserts are located, and limited program enrollment or engagement for a number of reasons. Our community's social determinant of health data dashboard, which you can see here up in the upper right-hand corner, really allows us to evaluate community disparities at a population level. We couple this data with intersections of information from our community information exchange, which Dr. Chen highlighted in his presentation, which really allows us not only to monitor what resources are available in community, but are they available and accessible to multiple communities in multiple languages? Are they led by communities of color? And are they not only receiving referrals, but are people engaging, and are they really satisfied in the services that they're receiving, and why not? Additionally, this information helps us to guide where programming may be lacking. And I'll highlight that in a couple of slides here, but we'll go on to our next one. Coordinated care uses both data intelligence, as I mentioned, and member referral needs and member voice to really deep dive into solutions to address inequities. And the case study that I want to share a few outcomes from is food access. This information was critical for coordinated care to inform both our program and benefit slides, which I'll talk about here in a minute, but I really wanted to highlight why it's important. Why is it important to not only look at data, what data tells us, what doesn't tell us, and really the most critical part is engaging in communities to listen, to really understand what we should do next. So we'll go to the next slide. Nationally, as outlined by the National Institute of Healthcare Management, health-related social needs or social determinants of health can influence more than 50% of health outcomes. This can further lead to continued health inequities in an intergenerational way. For example, for individuals who don't have access to grocery stores, affordable food options, or food options of cultural significance, they're less likely to have good nutrition or good nutrition practices. This can raise the risk of health conditions like heart disease, diabetes, obesity, and even lower life expectancy relative to populations who do have access to affordable nutrition or food options that are of significance to the communities that they come from. Just promoting health choices alone does not eliminate these disparities, which is why and how our approach to using data and community voice to build programming is critical. Next slide. As I mentioned to Emily, I could talk about this all day, but I really wanted to highlight how coordinated care has used data, community investment, and community voice to develop our portfolio of equity-based nutritional programs. These include the development of our member value-added benefit solution, our community investment model, known as 1 Million Meals, and our medically tailored meal palettes. And I'm going to go into each here and highlight some examples of how we've used equity, data, community voice to really speak to some outcomes and maybe some non-traditional outcomes that are of more importance or community significance. So we'll go to the next slide. Coordinated care evaluated data stemming back to pre-pandemic, so 2019, to really understand what our members need and what they want. And this is really to develop benefits that support the existing benefits of the Medicaid program or add to it. And from this, we birthed our Coordinated Care Harvest Bucks program, which is our fruit and vegetable prescription model in partnership with the Washington State Department of Health and the Safeway Foundation. We found that while our members may be enrolled in SNAP or WIC, they might be visiting local food banks or might have challenges getting to them, the rising cost of foods and needing to make difficult decisions on how to feed their families was of the most importance. The development of this program allows our members to have the autonomy to select fresh, frozen, and stable produce that they want and need. Since inception, more than 25,000 of our prescriptions have been prescribed to our members, which is more than 10,000 people total. Outcomes that we've been monitoring for this program include increased primary care engagement for our prescribers. Several of our contracted providers are prescribers of these, and they've used these as a way to incentivize engagement in practices, as well as in nutritional and education programs, which we've seen a significant uptick in participation and continued engagement. For example, in education on chronic disease, part of it was, how do we get folks there? How do we keep them engaged? And how do we talk about food in a way that is significant to the population and build community through education as well? Next slide. Through a combination of supporting both community health-related social needs and equity projects, Coordinated Care's 1 Million Meals campaign has actually invested more than $2.3 million in food and nutrition programs alone. These span both our equity and SDOH programs that I mentioned above. Some of the outcomes to date, by sitting down with different communities, organizations leading the way for nutrition, has really helped us actually to deliver more than 9 million meals to Washingtonians. And I think that the importance of this is this was at the beginning of the pandemic. And I think what we've seen is, while we can continue to invest, the rising cost of food continues. So there's not necessarily a great outcome to say, we've solved nutrition insecurity. I think the outcome here that's most important is that folks are talking about it. We see more news coverage for it. Organizations are really coming together at a grassroots level to say, how do we solve for nutrition insecurity, and what are the creative things that need to happen so that we're not only giving people more food, that folks actually have a choice. And one of the most critical things that we've learned from some of our food pantry partners or our community grocery stores or pilots that I'll talk about next is that just having access to foods, if foods are not familiar to you, you're less likely to eat them or consume them or know how to incorporate them into your diet. And so that's one of the biggest takeaways from our 1 million meals campaign is you really need to lean in and listen, and then try to help source things that people are going to be able to use so that they have autonomy and that they can be self-reliant in kind of changing their diet. We'll go to the next slide. Last but not least, our medically tailored meals pilots really focus on mirroring data, as I mentioned, to traditional medical health outcomes, community voice, and equity to really design and evaluate the impact of increasing access to culturally significant foods and nutrition. Right now, we have 5 pilots launched across the state in partnership with local providers and community organizations with the goal of improving health outcomes, lowering the total cost of care, and increasing patient satisfaction. Below are some of the preliminary results just from 2 of our pilots, but I think it's really important to note that while these pilots had positive results on some of the traditional outcomes, like lowering A1C and a reduction in hospital admissions, what's really critical to note is the long-term importance of engagement in community to increase sustainable access to nutrition. Second, and my favorite outcomes are actually the patient-reported successful outcomes, like reading more food labels and consistently reading food labels, teaching family members and communities on why it's important to do that. And both of these pilots and some of our preliminary results from pilots not mentioned here, we're seeing an uptick in that. We're also seeing an increase in participants reporting fewer barriers and their ability to get and consume healthy foods by connection to community and knowing where they can go in a way to pick up foods that are familiar to them. Last, I just want to share some lessons learned. I don't think any of this is news to us. If we can go to the next slide. It's important for us to really understand really what data tells us or doesn't tell us. It's also important for coordinated care. Oops, sorry, I froze. Can you hear me? Did I freeze for a second?
We can hear you. And I'm sorry, for some reason, this is the last slide that I have.
Oh, okay. That's okay. No, I'll highlight them for you. Again, data can provide valuable insight and guide strategy, but it's important to listen to where data is silent. Equity work takes time, commitment, community advocacy, and policy change to really have a long-lasting impact on equity, and where data really shows where we have options and outcomes that we can really lean towards. And then last, outcomes are more than a number. Again, patient satisfaction or participant satisfaction are really critical to really promoting community success and engagement in the conversation. So thank you.
Kelsey. As you're speaking, you're highlighting the significance and the importance of providing familiar foods for individuals. I would like to take that one step further, and I'm curious to learn about how you may be working to ensure that it's culturally appropriate foods and foods that are respective of the diverse cultures that coordinated care supports and oversees or has from their clientele, and how you may be able to use data to kind of inform that design.
I'll give you 2 examples. 2 of the initiatives that we funded, one to support a free grocery store model, and then 2 are medically tailored meal pilots. When we were sitting down with our food partners and community advocates, one thing that was apparent to us in traditional models is that if you have ever gone to a food bank, usually there's not a choice. Food is handed to you. And what we were hearing from our members and from community is that access to food is great, but if you don't necessarily, let's say, eat pasta in your diet, that you're more familiar with beans or grains, you're less likely to even eat the food that is given to you. So that was one way. 2, understanding diet, whether it's driven by religion or choice was really important, especially for how food is sourced, and making sure that our food partners are actively engaging communities to really put that on there so folks really feel comfortable consuming the foods that they are accessing in these free, either these grocery stores or meal boxes. And then third was, again, just having the choice. I know for folks, there's a lot of stigma in having to access nutritional support services, whether that's going to a food bank or food pantry or shopping at a free grocery store. Having the ability to do that in a way that humanizes individuals, that they can see the foods in front of them, that they can have conversations with our food partners to say, we'd really like you to source more mangoes, for example. We don't eat apples, which is one of the things that we've heard in our customer survey is we need to see foods that we understand or that are significant for us to help build the meals and bring our families together while we share a meal.
Thank you. I really appreciate that. We'll now transition to our fourth speaker, Dr. Josh Liao, and I'll invite him forward.
Great, thank you for the introduction, and let me see if I can match Dr. Chen and get my slides on the screen for everybody here. Okay, so really excited to join this group and be part of this Catalyst for Change series. Though, as the introduction mentioned, I do hold a faculty position at the University of Texas Medical Center. A lot of what I'll talk about today is based on work that I've done in Washington State, where I'm still fortunate to have an affiliate position with the University of Washington. So before we jump in, I just want to say that the views that you hear today are mine and mine alone, and not necessarily reflective of those of my employer, the groups that I'm really fortunate to be affiliated with. And I do receive grant funding from a number of groups at the National Institute of Health to study projects and topics related to healthcare value and equity that are attended today, but these are kind of beyond the scope of what I'll share. I'm going to show you this value equation, and it's probably very familiar to many of you. We won't unpack it, and we won't spend a lot of time on it, except to say that I think what I consider to be a good thing is that over time, we've recognized that really to drive value and quality and cost efficiency in a thoughtful way, we really need to be thinking about disparities in health inequities. But it's not really inherently encoded into the quote value equation that many of us think about. And I think it's a really important thing that's centered my work and the work of collaborators that I've had a chance to kind of do evaluations with, which is to say that there actually is a world in which we can focus on quality and value and miss the mark on equity. And I'm really excited about this series, among other things, and the organizations that have convened this session to really push on that issue. My work has really been kind of in a few different groups. It started in Washington State in this group called VESSEL, the Value and Systems Science Lab. It's evolved since that time to this thing called Propel, which is the Program on Policy Evaluation and Learning. And the point I mentioned is just to say that I really have tried to do a few things through these groups that I've been fortunate to co-lead and found. And I want to just review a few principles before we dive into a use case. So the first is really intention and goals. And what I mean by that is, as I just alluded to on the prior slide, there is a way to focus on value and quality without equity. I don't think it's the full solution. I don't think it's the way we should do it. And often I think equity becomes a bit of an unintended consequence. This is often how it's described. And I think we missed the mark there a little bit. I think that aspirationally we should intend to address equity and remove inequities in the things we do in the value space. And so I think setting that explicit intention is something that guides our path. The second principle is multi-stakeholder perspectives. This is obviously easy to say and much harder to do, and it takes time, but I think it's time and energy well invested to think about whether you're speaking out with someone like me, who's an academic physician or a public entity or community-based organizations or members of the community that one is considering, really making sure we get perspectives there. That's also driven us in our work. Data and measurement, I won't say more about that because we're about to get into that in a few minutes, but very important. And finally, rigorous evaluation. So thinking about, how do we not just take data? Data needs to be translated into insight and insight into actionable insight. And so we really take this last thing very seriously. So, across these two groups, I've really been honored to lead or co-lead a portfolio of work. And I want to end today, kind of our panel here, maybe to end where we began. I'll give you an example of a collaborative process that I was honored to work with the Healthcare Authority and others on that I hope brings to life some of these principles and offer some insight into the topic for today, which is where do data and where does analysis live in trying to address value and equity. So the project I'm going to tell you about is entitled Understanding Telemedicine Use Among Native Hawaiian and Pacific Islander Individuals Insured Through Medicaid. This work was funded through the University of Washington Population Health Initiative and partnered with the Healthcare Authority. So a little bit of context for those who may be less familiar here. These individuals that self-identify with these communities, or NHPI, have long faced inequities along a number of areas, and I think those are exacerbated by COVID-19. Washington implemented a number of changes to increase access to telemedicine in the context of COVID for individuals insured through Medicaid. And I view this as a decided positive. But the question, of course, remains, did these benefits get experienced equitably or not? And in the desire to kind of add even a few ounces of data to the ton of opinion, we wanted to do a rigorous evaluation to bring data to bear on an issue that addresses value, telemedicine, but to do so in a way that also co-elevated equity as well. And it was important for us to do it in this population because I think the knowledge gaps around equity are particularly problematic for groups such as NHPI individuals, which are often kind of erased from data given data missingness, lack of data granularity, et cetera. So again, I hope this is an emblematic case of how we have really used data around value and equity. So what do we set out to answer? A few things. First, how did telemedicine use compare between NHPI and other groups? Here we chose non-Hispanic white individuals as a comparator, insured through Medicaid. And then what were some of those drivers of the potential differences in use? I promise to keep the methods very light, but for those who are more kind of data inclined, we are talking about data and analysis. So one quick slide on this. We use comprehensive claims in Washington State for Medicare beneficiaries. We looked at a bunch of variables. The X, so to speak, was self-identified race and ethnicity. The outcome, or the Y, was telemedicine use. And we certainly tried to be as thoughtful as we could based on our conceptual theory for individual and community level measures that we put into our analysis to account for or adjust for these things to make sure we could really isolate the relationship that we were looking for. In a word, very oversimplifying it, we used regression and decomposition analysis. And again, this speaks to the rigor that I think when scholars apply their best can really bring to bear on important value and equity questions. I think most of you are probably familiar with regression. Let me just dive in a little bit on the decomposition and say kind of like what is it and why do we need it? The point of decomposition is to understand and quantify how much of a difference that you find between two groups is due to three particular things. The first is observed characteristics between two groups. So some difference in an outcome, like telemedicine use, is it because of different educational levels? I think that's pretty straightforward. But the wrinkle here, and I'm happy to answer this in Q&A or offline for anyone who's interested, is that you can actually have the same level of a characteristic and still have differences in associations, meaning you could have the same level of education or the same level of wages, but still see differences in an outcome. And it speaks to other factors that are at play. And you can certainly see the interaction between these two. This is pretty text heavy. Let me give you kind of this in an image for those of you who are more visually inclined. So say, for example, you're looking at, you find an overall difference between two groups. And the example I'll use, as suggested on the prior slide, is wage differences between two groups. You might think about differences coming from differences in observed characteristics. Perhaps the wage difference you see is driven by different levels of education between those two groups. But there's another source here, and this is the rub, which is there could actually be differential associations based on the same characteristic, meaning two groups could have the same education levels, but still wages are different. And it begs the question, why? And then you can have the interaction between one and two. So the reason to do all this advanced statistical modeling and analytics is not because we can do it. It's because we're trying to unearth kind of layers of things that can elucidate the inequities we see in a meaningful way. Now, this is pretty technically heavy, but as I mentioned earlier, multi-stakeholder perspective is very important to us. In this project, we were honored to have input from a community advisory board, which reflects a number of community-based organizations that represent and have constituencies from the NHPI community here in the state. So let me get right to the results. And I'll kind of give a couple high-level ones and then end with a few implications. So the high level, what we saw was that there was less telemedicine use by NHPI individuals compared to non-Hispanic white individuals over the period. That's what you see here in this graph. The higher red, dark pink line is the non-Hispanic white population, and the lower kind of blue line is the NHPI population. When you then run the regression and look at the numbers, what you find is that, relatively speaking, there was a 38% less likelihood to use telemedicine among NHPI compared to white individuals. So take home, we see a difference, right? Now our job with the decomposition analysis to figure out why, and is it the more intuitive, because the variables differ, or is it the less intuitive but incredibly important, the variables don't differ, but there's something else at play. And so this is a table showing you kind of factors that are associated with greater odds or greater likelihood of using telemedicine during the study period that we had. And you can see a number of these. We looked at the other side as well. What about the other side? What about factors that predict lower odds of using telemedicine? You see a few things here on house status, as well as residents in an area that has a shortage of healthcare organizations and clinicians. So another way of thinking about this on an absolute scale is we saw a 7.5 difference, okay? Lower use of telemedicine among NHPI individuals. Where did they come from based on that same figure I just showed you a few slides ago? Was it from differences in observed characteristics, education level, income, et cetera? And the answer is no, actually. Very little to any of it came from that on an absolute level, less than 1%. The lion's share actually came from this differential association thing that I'll unpack in a slide or two, and then just a little bit from an interaction effect. If you sum those three, you get to 7.5. And the take home for the non-technical individuals here joining us is that much of the difference that you would never have known had you not done this additional decomposition is actually coming from differences that you cannot see just by differences in a variable in the regression model. So walking through that a little bit, I'm going to show you an array of those variables in which we saw these differential associations. And so the first I'll give you is age. So anything that goes to the left here is showing you a decrease in the gap in telemedicine use. And so for age, what we saw overall, if you don't do the decomposition, you don't look by subgroups, what you see is that overall being older was associated with less telemedicine use, okay? But then if you do the decomposition, what you'll notice that among NHPI individuals, that association was muted. In other words, being older was not associated with as big of a decrease in the use. So there's something going on modifying that association for NHPI individuals in particular. You can do that same thing for poverty level or income level. If you flip to the other side, what you'll see is that preference for spoken English, same thing. How would you interpret this? You would interpret this by saying overall, preferring English as a spoken language was associated with more telemedicine use. And yet when you decompose, what you see is that that association is not as strong among NHPI individuals. And you can do this across a number of variables, and this is what you see. Some are more muted, some are less muted, and it kind of adds another layer of color and context to the findings that we see. Now, we showed this to our community advisory board, and they gave us a number of pieces of feedback, including, well, this is very important, but there are data limitations. There are certain cultural preferences for in-person versus virtual visits. Our advisory board members were very helpful in helping us understand some additional factors that could influence this use that we could not see in the data. A really rich information that I think is going to inform our future work. And then, of course, concerns for cost of access. So a couple conclusions from this use case are that these NHPI individuals insured through Medicaid were less likely than others to get telemedicine in the study period, and that these differences do not come from the factors that you can see in differences, the standard statistics and regression models. Instead, actually, these differences came from those more nuanced differential associations that we observed. Now, this is one case, again, in a broader portfolio of work that we do. What do I hope you take away from today, above and beyond maybe content interest in this? Is a few things. The first is that I think one implication is that it's important to identify these differential associations because they reflect things that we can't see in the data, but really need to be excavated and unearthed, including, in this case, particularly limited acceptability, access barriers, unique preferences, structural barriers. And we really need more evaluation to further tease these issues out. And the ultimate goal, right, is to design tailored efforts, in my opinion, that broad-based, even well-intentioned efforts may not actually do what you want them to do. In our case, increase telemedicine uptake among specific groups if they're not tailored. And in not doing so, we won't achieve equity in our value goals. So final slide here. In terms of evaluation implications, that was the topic of today. You know, how could we get here? We could not have done this without data fidelity. You heard Chen talk about this. You know, without the granular and complete data at the state, we couldn't have done this, full stop. I think much needs to be said about that. The second is we needed to have access to the data, and that involved collaboration between community, organizations like the Healthcare Authority, and scholars like myself. And again, while one use case, I think these are the key ingredients to the type of thing that can unlock data and analysis to address value and equity. So I want to say thank you to the Community Advisory Board members, our partners at Medicaid, and members of the evaluation team. I know I'm over my time, but I hope this gives you a little bit of context where we're at 30,000 feet zooming in for one case of how we can do so. So I thank you for your time, and I'm happy to take questions.
Thank you so much, Josh. As you were presenting, I had this thought and I was hoping you could elaborate on it. We recognize using a community advisory board and hearing the voice of the community is so vitally important. However, it can be hard being a healthcare institution, being the government to build these relationships. Could you speak a little bit about how you were able to develop this community advisory board of trusted relationships?
Yeah, so let me just say from a position of true humility, we don't have it on lock. I think as we've tried to do this with different groups, we've had to approach and had the chance to learn to do it differently. But I think a couple of principles surface here. The first is that I think leading with this is important rather than saying, hey, here's a project we want to do. Can you just kind of co-sign or kind of come along for it? I think that was very important. Number two is to kind of like empty ourselves of kind of the dangers of expertise, like, oh, we've done this in the past with certain groups, so we can do it this way with these groups. I think that was very important for us. And then the third is to make sure we stayed in close contact. The stuff I showed you is dense even for scholars and academic researchers. You can imagine for community members even more so. And we had some challenges translating the message we took upon ourselves. But I think having close contact and really spending the time to do that was important.
Well, thanks. We'll now transition over to our panel presentation, where I'll invite Emily Transu to be the facilitator and the rest of our speakers to come forward as well for this portion of the presentation.
Try to keep all the questions to one Emily or another. Just helps to maintain a little continuity. Thanks, everybody. This was amazing to listen to each of you and how these different pieces connect to each other. Curious, what is people's data wish list? What do you wish you had that would help you to take meaningful action around equity or make inferences? Particularly thinking about things that might be in the relatively near-term horizon. What should we be working toward in terms of data? Anybody can jump in.
Well, I'll jump. I think a few things. There's a lot of survey fatigue, and I think Dr. Chen can speak to this from a Medicaid perspective. I think we're really trying to align at an organizational level how we ask questions, the education needed before you ask the question, and then how do you really interplay the different systems or EHRs that providers, practitioners, community organizations do. And I think one thing that is really exciting to me is alignment on a national level from NCQA for the social needs screening, the electronic version, or the SNSE measures, and really coming together as a sector to say these are the ways that questions should be asked. There's a standard way for data collection following the national standards for those questions. And I think following that up with a reimbursement from Dr. Chen's presentation, it's really the incentive to continue to ask these questions in a meaningful way that gives us a better or more complete representation from data. That said, I still think that it's a little bit further out, and I think it's a really ambitious goal for us to do that. But I think standardization and continued conversations on how to shape the way that we ask questions in a meaningful way is really what's going to position our state for success.
Thanks, Kelsey. And I was just going to add, yeah, I think, and maybe breaking it down both into the structured and the unstructured data from a structured data perspective, I on my wish list would just be more standardization. And I think this one's tricky, even though in healthcare, we have lots of standardization in terms of ICD-10 codes, CPT codes, et cetera. it's still not necessarily consistently collected to and kind of when you kind of think about social data and how that can be much less standardized, I think that the problem is just magnified in terms of like, how do we really understand the barriers facing the population that we serve? And on the from a data wish list perspective on unstructured data, I just think there's a whole host of information about the client experience, the patient experience that we're not capturing. Why was someone not able to access their benefits? Where in the process did things fall through for them? What was their experience, positive or negative? And maybe with evolving technologies, we'll be able to gather more of that patient experience data. But I think that would really help in the journey to quality and equity.
Thank you. Josh?
Yeah, I mean, I echo a lot of what Kelsey and Chris have said. I mean, I feel that the first principle for me here is that if what we're talking about has to be gathered ad hoc or above and beyond standard business and operations, we're always going to struggle because there's always going to be an arc of it, and here it comes again. And I think Chris highlighted it. We gather a lot of information at granular, too granular sometimes, levels. And I think I would love to see, for the topic we're talking about, more standardization and just more defaults to gathering information on the issues that we care about. I mean, I don't think anyone has it completely perfect, but there is a lot that can be done if the data that we have are complete. And I struggle with this idea of not being able to capture all the data we want, but then continuing to talk about the inequities that we see from that. And I think that would be my wish list, that we would work it into ongoing operations so we don't need separate surveys and separate initiatives or grants to do this.
And I'll just add a couple thoughts as well. Totally agree with my colleagues here on standardization and the apples to apples, like I mentioned earlier. And I think also the lenses on our communities as it pertains to real SOGI, people with disabilities and the like, as well as from a provider perspective, provider directories to see competency and capacity to support specific populations. That's all top of mind on my wish list. But I think in addition, when I think about what Josh just said about making things part of standard business for corporations who have to rationalize investments, we're talking about investments beyond grants and Medicare, MA 1115s. For a company to invest in something, I'm going to need to prove ROI. And the best way to do that, I think, is taking a look at the full value that a benefit or a program can bring to bear across not just healthcare claims, but disability, turnover and attrition, absenteeism, presenteeism, workplace culture, all of those things. And I don't know that the industry has really really great mechanisms to figure out that full value equation quite yet. That's my wish list.
Thank you. I appreciated your distinction between return on investment and value investment and that sort of higher way of looking at these questions. I think there was a comment, this may have come from you, Josh, around sort of starting with equity and then adding other components or starting with the rest of it and kind of tacking on equity as a secondary thought. And I'm curious from any of you in this work of examples of how you've taken one or the other of those approaches and why.
Yeah, not a small question, but an important one. So thanks for asking it. I think, what in my work, the tension, I think a healthy one that I try to hold is things that are imminently pragmatic and practical that can meet the needs of our communities now, but also things that are aspirational. I think, too far the one way or the other, you get into some tough challenges, particularly for the topic at hand. So in the example that I gave, it couldn't have happened if we didn't have complete and granular data. But then we had it had to be the lead piece of that, right? So to do the work that we described, it had to be that we could identify granularly with some accuracy and completeness who are those individuals that self-identify. as Native Hawaiians and Pacific Islanders separately, and then combine them and ask the tough question of should we and how should we do that? So that to me represents a kind of like it's data that the state is gathering that we can use, and it can be more quickly implementable. But I continue to feel that, you know, and I think back to the wish list that was just articulated a couple seconds ago. We're not going to be able to address that, in my own view, unless we lead with equity first, and we either compel or create as a default certain ways of gathering those data. I think the only bad outcome to me would be to continue to aspire to those things and not require the data to come along, and certainly wouldn't support that approach.
Maybe I'll chime in with just one additional thought on that is from a purchaser perspective, I think we've tried to put equity into part of doing business. So one thing we did last year was created an inaugural set of social health and health equity standards, and we put that into our RFI RFP process so that as we're assessing new opportunities, part of that scorecard is ensuring that no one gets left behind. It's granular things like, well, simple things like languages and accessibility with our digital offerings, in-person offerings, what kind of hours are we talking so that people who work a 9 to 5 can still access care? Do we have weekend hours? The list goes on and on. But until it becomes part and parcel, I think it'll always be an afterthought to Josh's points.
Kelsey, I agree with everything that's been said here. I think when you don't center your work around equity, you end up with things that are ineffective. Data is either skewed or underrepresented or overrepresented to one population, or there's lack of engagement. And an example I can give is from a health plan perspective is when you design a value-added benefit, you might think, hey, and not to say, I'll use car seats as an example. Car seats are critical, life-saving, right, for children and families. Not all children and families have vehicles. And so if you don't give a choice, and let's say that another option is safe sleep, or the car seat that you're providing is a stationary car seat, and it's not one that you can actually carry on the bus or to the bus stop, right? We lean in and say, we know these things keep people safe and have longer health outcomes, but when you don't actually engage the population and really understand the different unique needs and access to transportation and how transportation is used, or if, you know, the primary caregiver in the home, if it's culturally significant to them to drive, the benefit isn't really effective. And so that really gives us the opportunity to go back and use community voice and really think of different ways to engage community to say, well, what is important? We have this idea that this is important, but maybe it's not. And so I think that that's where you kind of find yourself in healthcare cost waste when you don't actually start with equity.
And we can add one other thing, which is that I think from my corner of the world, I think it's very easy sometimes for perfect to be the enemy of the good here. And, you know, one of the most dangerous things to me is to say, not to say no in this space, who's going to say no, but to say not yet. Well, let's wait till the day is perfect and 100%, and we have it all, and we don't need NLP and AI, we don't need extra surveys, we don't need any of that. You know, I'm not holding my breath for that. And I think we actually have real life examples from parts of the country where what we have can be good enough with just 1 or 2 steps, you know, and happy to talk more about that. But, you know, like look at the example that I gave. It was a bit mind-bending for me to think about why English as a preferred spoken language would be so different in what it was telling us about NHPI versus non-Hispanic white individuals. You could have said, well, English as a preferred language is not a perfect variable. We could have beat it up, right? But it got us into the zone of asking these questions that we then brought back to our community advisory board. So I think there is a way to make progress. And I would say we want to be thoughtful about what we do, but perfect can't hold us up.
People walked away with nothing else but that would be a great reminder for us all. I think I want to encourage people to put questions into the chat, and also I want to give an opportunity. I have lots of questions, but if any of the panelists want to ask each other questions, feel free to do that as well. If you were, while you're thinking about that, if you were giving advice to someone coming into this space who might not be as far along as you are, or if you had to go back and wish that you'd known a couple of things, any thoughts around gems of wisdom you've picked up along the way that would have been great to have earlier?
I'll kick us off with this one. I think one thing my mentors always put into my brain was the power of coalitions, because no one entity or person knows everything and has expertise in everything. So, for example, I'm a primary care doc, but I'm not actually very good with numbers, and so I definitely partner with economists and statisticians to dive deep into data. You know, I don't have every type of lived experience out there, and so I need to learn and listen. And so I think one thing that I have learned that has been very helpful is just building partnerships, learning from others, and collaborating as much as possible.
Yeah, oh, go ahead, please, Emily or Kelsey.
Oh, sorry. Thank you. No, I was going to say I agree with everything that you said, John, and I would add, be comfortable being humbled as well, right? You can bring a group of people together, but a lot of folks, when they bring a group of people together, they're from similar minds, and that often ends up with a bias towards having a similar idea or approach. So I think it's one, being comfortable with that. Your people are going to make mistakes. You need to think outside of the box in the groups of people that you normally would go to, or coalitions that you would go to. And it's more important of what you do after you're humbled, and look at ways to incorporate community voice into moving forward, versus kind of that paralysis of not being able to move forward because of a mistake.
Yeah, what I was going to add, you know, for me, among many many other lessons, is that I think because of where we've come from in healthcare, and I focus on healthcare in particular, there's often this, I think, this like viscosity around more data. Like, oh, here we go again. You just want more HEDIS, more data collection, more ICD codes, and I understand that, but I think it's important to recognize how kind of chimeric we are in the data. We have lots and lots of data, lots of granular data on some things like clinical care. I think as a internal medicine doc, you know, like I have so much information about kidney function and renal function, electrolytes. And yet when we think about non-medical drivers and social drivers, we are just the beginning of that. We don't have that same kind of granularity. So I think there's sometimes this kind of backlash of, or do we really need more? In my opinion, yeah, we do. Because otherwise it's going to be very imbalanced, and we shouldn't let fatigue with the one impede us in the other.
One question that's come in from the group is about how community members and patients, or those who are directly impacted by disparities, are being engaged and involved in these efforts. Things like data validation, prioritizing foci for research, how initiatives are defined. Josh, I think you gave us a great example of some of that, and Kelsey, you did as well. Any other examples of that, or other pieces?
So this is Chris. I'll just add for Healthcare Authority, there's of course we serve a public good, and our work is kind of really, and our agencies are really dedicated to engaging the public and in getting feedback and input on the direction. Certainly for some of the work that I described today related to data collection and standardization, where our goal is to establish more robust community engagement for measure review, for data review. I think many of the projects, like the SOGI work group that I mentioned, are done in partnership with specific organizations, kind of speaking to the importance of working in coalitions, as John mentioned before. And there's kind of other mechanisms like our community advisory councils for engaging as well, but always open to feedback and input from the public.
This has been great. I wish we had lots of time. John, do you want to answer quickly?
That's okay. I was just going to talk about voice of the customer again, but
And appreciate that you did that earlier as well. Thank you. I'll hand back to Emily.
Well, thank you all for being here with us today. We just want to take a moment to kind of wrap up. Just as a reminder, this webinar is recorded today. If you could take a moment and please provide us with your feedback in a post survey. We've posted that link in the chat. We would really value your feedback as we work to design our third webinar that we intend to host in September. We'll let each of you know about that event as we work to plan it. We also wanted to let you know too, we have an upcoming event on June 25th from 12 to 1:30 p.m. where we were highlighting addressing food insecurity in Washington State. Kelsey did a great job at highlighting the work that coordinated care is doing on this topic. We're going to delve into this some more, learning more from DSHS, DOH, the Department of Agriculture, and a fruit and veggie prescription box that's in Skagit Valley. But we want to thank each of you for attending today, but also our speakers, our panel, planning committee, everything that went involved in this presentation. But thank you so much to our speakers for providing us with your time, knowledge, and expertise. We are really grateful for you joining us today, and we hope everybody has a great day, and thank you so much.
Thanks so much, all.